Yeah, it's great, Dr. Arjmand. If you can just put it in the speaker, yeah, that's good. Full screen, it'll go even, it'll go even fuller. We would take it.
Yes, let me figure that out.
But that's not a bad view right there, and they display well, so that's fine too.
Yeah, no, I don't know why I know I can do it. Let me just.
Yeah, that looks good.
Okay, so that's a fuller screen then. All right, how can I minimize that?
If you can stop sharing as well for a second there, Dr. Arjmand.
Sure.
Perfect. So, Dr. Bernard, Dr. Broker, I'm going to start if it's okay. It's noon already.
Just looking for Dr. Kong. He's the only one I don't see. It is 6 a.m. in New Zealand. We got him up early today. And Dr. Henry.
Dr.
Guest,
Can you hear us? Dr. Warner?
Dr. Warner.
Yes, sir.
There we go. Perfect. We can see you. Thank you for joining. So we're still waiting for Dr. Henry and Dr. Kong. Is that right, Andrew?
Yes. Yes, sir, that's correct.
Justine, you're still good on audio. Perfect. Maybe we can get started with some introduction. My name is Jose Pascual. I'm dialing in from Philadelphia as member of the International Relations Committee. I wanted to welcome everybody to the International Virtual Case Presentations, which is a joint PTS, Pan American Trauma Society, and AAST, American Association for the Surgery of Trauma effort. Now, the PTS has been doing this much longer, for over a decade, where they do this weekly and they present cases from all over the world. And the AAST is fortunate to join the PTS in this effort once a month. If you're interested in presenting your cases from all over the world, please email me or Carlos Mendigozo from the PTS to send us your cases. I'm going to defer to our two moderators for today's session, Dr. Andrew Bernard from the University of Kentucky College of Medicine and Dr. Justine Broker from the Gallup Indian Medical Center, to proceed with two case presentations, question and answers to the panelists, and then hopefully finishing in time, so a maximum of half an hour each. Dr. Broker and Dr. Bernard, go ahead.
Thanks, Dr. Pascual. These are always really a treat. So I appreciate the opportunity to moderate this session. Dr. Brecker, would you like to introduce yourself first, and then I'll introduce myself and the moderator, the panelists?
Sure. I think Dr. Pascual went over it already, but I'm Dr. Justine Brecker. I'm a general surgeon for the Indian Health Service. Excited to be here.
Thanks. Yeah, I'm Andrew Bernard. I'm in Lexington, Kentucky. We have three panelists today, and I'll introduce them now. I think Dr. Kong is probably just still coming on, and Dr. Sharon Henry. But Dr. Zach Warner, my partner, is Associate Professor of Surgery here at the University of Kentucky. He was educated here at UK in medical school and in surgery, and then went to LA County USC Medical Center for his trauma fellowship, and then came back to Kentucky. He is the trauma medical director for our Level 1 Trauma Center. He lectures internationally in the areas of chest wall and other areas. So he's an expert in this, and he's excited, to participate. Zach, thanks for being here. Our next panelist, Dr. Victor Kong, he's Associate Professor of Surgery at the University of Auckland. He's from Hong Kong, did his medical education in South Africa, and then back to New Zealand for surgery, and has done fellowships, including in Ireland and in Australia and at Sunnybrook in Toronto. And he's heavily involved in the system of trauma care in New Zealand. So it's one of our other panelists. And our third panelist is the current president of the Pan American Trauma Society, Sharon Henry. She's the Ann Scalia Professor of Surgery at the University of Maryland. She went to medical school at SUNY and did surgery there, and then did her fellowship in Minnesota when Frank Serra was there. And she's widely recognized expert in nutrition, wound care, critical care, surgical infections, and as I said, current president of the Pan American Trauma Society. So it's a great partnership here, AAST and the PTS. So I'm going to roll right in by introducing our first speaker. I'll just say Dr. Arjmand and Dr. Matecki. We're not taking your old boards here. I know this is stressful. It's an international case conference, but this is the trauma family. So you can just relax and present your case, and we'll talk through it with you and ask a bunch of questions, I'm sure. I'm going to start with Dr. Mary Matecki. Dr. Matecki is at GW in Washington, D.C., and her mentor is Babak Sarani. So, Dr. Matecki, you have the floor.
Thank you guys so much. Let me take a second to share my screen again. Let's see. Sorry, it's moving around a little bit. Share. All right. Is it advancing for you guys?
Perfect.
Okay, awesome. Yes, so my name is Mary Matecki. I'm a PGY5 in the Department of Surgery here at GW. Thank you guys so much for having me for this case conference. I have no relevant disclosures for this case. The objectives here are prioritizing the management of severe intrathoracic, intracranial, and intra-abdominal injuries, and the application of VV ECMO in a trauma patient with a severe pulmonary injury. So we can get into the case presentation now. So our initial call-in is a 30-year-old male with multiple gunshot wounds to the chest, abdomen, right arm, and head. He's GCS 11 in the field for EMS, and he's hypotensive. EMS tells us that they're giving whole blood, TXA, and calcium. More collateral that we get from the EMS report is that he was one of multiple individuals at a location with gunshot wounds. The EMS crew placed a right humeral IO and put him on 15 liters of non-rebreather and placed multiple chest seals and did bilateral needle decompression. His initial vitals were up to a heart rate of 130, the blood pressure as stated, and a O2 saturation of 89. In the field, he was a volume responder. They gave him 1 unit of whole blood, followed by TXA and a gram of calcium, and his blood pressure came up to the 80s over 50s and lowered his heart rate. So they gave a 2nd unit of whole blood, which brought his blood pressure up to 129 over 72. Of note, the EMS team was able to activate and act pretty rapidly. They were able to get to the patient and start transfusing whole blood in about 13 minutes and then transport him to the hospital about 10 minutes later. When he arrived to the hospital, we noted that he had a clear airway but had shallow agonal breathing and had distal pulses with cold, clammy extremities. Immediately, his GCS was poor, so we made a decision to intubate. And our vitals on arrival were similar to the last set that they got in the field. Heart rate of 110, blood pressure of 120 over 80 with a O2 sat of 86%. In brief, the secondary survey noted a hematoma and laceration to the left scalp and wounds to the sternum, right chest, and left chest, and a single wound to the epigastrum. He also had a puncture wound, multiple puncture wounds to the right forearm that had active bleeding, so the trauma team placed a tourniquet on the right upper extremity to temporize that. The team placed bilateral chest tubes with a small amount of blood from each side of the chest. However, shortly after the chest tubes were placed, the patient lost pulses, so a left anterolateral thoracotomy was performed. They had actually a large amount of release of blood from the left chest, and of note, when they examined the pericardium, it had a small laceration and there was blood coming up from the hole in the pericardium. Pericardium was incised, and it appeared that they released some tamponade that had occurred. The heart on inspection had adequate filling volume and squeeze. There was no gross cardiac injury that they saw during their trauma bay thoracotomy. He also had a left upper lobe laceration that was bleeding that they packed some. The patient had return of pulses after the thoracotomy and with the release of the pericardium. So the team proceeded to the operating room and consulted cardiac surgery to join us there.
Okay, Dr. Matecki, wow, you've given us so much here. We could spend an hour talking about just your first few slides here. Complicated case. Did you say the patient got blood in the field?
Correct. He got 2 units of whole blood.
Yeah, and this is it's been a big effort, I know, in the DC area. And your mentor, Dr. Strani, has been a powerful force in getting whole blood in the field there. It's whole blood, yes?
Correct. It's whole blood.
Yeah, great. Maybe we could take a comment from our panelists on the value of pre-hospital whole blood.
Yeah, I'm happy to comment. I think the timing makes me jealous, right? Our catchment and referral area here in Kentucky is a little bit different than what you deal with. So challenging for us to take a finite resource and make it quickly available at the point of injury. So that timing is outstanding. And I think to be able to administer that rapidly before the onset of coagulopathy is really what I envy about that time frame, right? Gives you the opportunity to hopefully address some of the loss before they get to definitive hemorrhage control. In our system, we don't have enough whole blood at sort of the locations where we need it. So we've elected to place that with one of our chief vehicles to go meet the team, right? So it may not be on the buggy right away, but sort of intercepting them, but it potentially delays, right? That exchange may take some time. But Dr. Bernard, I think our practice here, I think he and I are both quite envious of that initial timing and timeline that you advertised.
Now, we heard John, go ahead. We heard John Holcomb at the COT just a couple of weeks ago say, big audience, say pre-hospital whole blood is more impactful than anything we do at the trauma center. It's John Holcomb, so it must be true. I thought that was a really profound statement. The IO, value of IO in a trauma case. I used to poo-poo the IO. It's in a bone. What's it really going to do? But Brian Dumas has carried this torch and IO in trauma for a good while. Thoughts on IO for any of our panelists? I don't know if Dr. Henry or Dr. Kong are on yet. Zach?
Yeah, I think that I sort of similarly feel a little bit similar to you. I'd like something shorter in a vein, if able to do so. But I think what's reproducible, despite the extent of hypovolemia, is that access site, right, and the ability of an IO to obtain that no matter what. And Dr. Matecki, I'm curious, is that something that you're a big proponent of, or when they arrive, do you rely on that, or do you move pretty quickly to venous access?
We have excellent ED techs and nurses who can get very good venous access, but in these patients who are so volume depleted, if they come in with an IO and we can give them anything through that IO, I think that's really invaluable in these patients who are just like in extremis with no blood pressure, because then our techs will have issues, finding good venous access.
The comment in the chat from Dr. Taveras, maybe the orthopedists are right all along, the bones are where it's at. I'll just ask you one more question because I know there's a lot to cover. Needle and or finger thoracostomy in the field for any of the folks who are regulars here, Dr. Untrack, Dr. Cassim, Dr. Frisbee.
Yeah, Dr. Matecki, I'm interested. You said that they were decompressed bilaterally. So how could you have still had blood in the chest?
Yeah, I mean, I don't know that the decompression was actual decompression as much as chest wall needle placement. We'll never really know in this patient. But I think in somebody with severe chest trauma, it's, I don't know, it can cause harm. But in somebody with extremis, it could potentially cause some good.
Yeah, I think a couple of points, right? And there's a reason the 10th edition of ATLS one moved the location for needle decompression right out laterally because we're thicker up top. And I think a lot of times we've shown in cadaver study and our personal experiences that we don't always make it into the chest. And there's also an opportunity to hurt things, right, more centrally, depending on your understanding of that anatomy. But I don't teach people to needle, right? I don't believe there's a place for it in my trauma bay. I think a finger thoracostomy is the skill set that we should be pushing if we're able to do so. There are certainly folks who don't have the skills that we do that maybe a needle is as much as we're going to get. But the reliability of that intervention to get them adequately decompressed, I think this case highlights that really wonderfully.
Okay, we're going back to the case now.
I think Dr. Kasim had a comment or a question.
Yes, sir. Question. Yes, ma'am.
I believe in trauma cases, finger thoracotomy is a lot more useful than needle thoracostomy. And if you have significant injury, I think it is better to go with finger thoracostomy as long as your paramedics are trained to do that properly. Thank you.
Yeah, we're seeing more and more paramedic services ask us here at the trauma center to come out and do training for them on that. So I think the popularity is growing. Okay, we're back to the case. The chest is open. Dr. Warner, nobody dies pretty much without a thoracotomy in LA County. So I know you're going to have thoughts on this. The chest is open. There's blood coming out of a laceration in the pericardium. Okay, Dr. Matecki, take us forward.
So we proceeded to the operating room. The trauma surgery team localized the bleeding in the left upper lobe and performed a tracheotomy and wedge resection to control that bleeding. They converted the initial thoracotomy to a clamshell incision, and the pericardium was explored. There was the laceration to the pericardium, which had already been visualized, but there was no underlying cardiac issue, and they performed an intraoperative echo to confirm that. Because there was concern of cardiac herniation with a large defect now in the pericardium, they closed that with a bovine pericardial patch and left a drain in the pericardial space and closed the chest. Additionally, while they were in the operating room, they noted that the right upper extremity was still, had that wound that was tourniqueted off before. It was a radial artery injury that they explored and were able to ligate with good distal perfusion afterwards. If you'll remember, there was the single wound to the epigastrum, and so the team had to decide what to do about that, not knowing the exact trajectory of that wound. The patient also had a wound to the head. He had stabilized during the case after the chest was, decompressed and then closed. He was not requiring pressors or actively being transfused, and he had received a moderate amount of blood products for somebody who got a thoracotomy in the bay. So the trauma team made the decision to complete imaging, basically a pan scan of the patient, keep the operating room ready if they were to need to return to the OR for abdominal exploration. And so here's some representative slices of postoperative imaging. You can see accommodated fractures and the area of the lung that was lacerated now with chest tube in it. Here's some lower images showing some hemo and pneumo peritoneum. And then there was noted to be an extensive complex fluid density around the stomach. And as we said, hemo and pneumo peritoneum, concerning for an injury to the stomach. And so the decision was made to—
Let me just, Dr. Matecki, let me just stop you for a sec.
Sure.
I'm going to take you back. I remember this thoracotomy unfolded pretty quickly, so I'm just asking a question of clarification. There wasn't a sonogram in the trauma bay. Is that right? That's question one. And two, did you have any plain films? Did you know at least where the projectiles were?
So normally our ED team does an abdominal FAST in the trauma bay. I don't know if they got pericardial views. I don't recall. And then I do not believe they got to the chest x-ray portion of the adjuncts at this point.
So the ED arrest happened before you even had films, so you didn't know where all the bullets were?
Correct.
Got it. Okay.
Yes, so these are some slices of our abdominal imaging, and then we performed a CT head. which demonstrated the findings here. You'll recall the laceration on the head was actually rather small, but he had retained bullet fragments within his skull and a skull fracture. Those ballistic bony fragments in the frontal parietal lobes, and then subdural, subarachnoid, some sulcal effacement, and a minimal subfalcine herniation. So that was kind of a surprise given his head exam in the trauma bay. So the next steps in the injury triage. Trauma surgery returned to the operating room for an exploratory laparotomy, and we consulted the neurosurgeons to meet us there. We identified a grade 3 liver laceration with active bleeding and a grade 3 splenic laceration that was not bleeding. They packed and then cauterized and applied hemostatic to the liver surface. He had a macerated injury, almost sort of a skive injury to the anterior surface and lateral curve of the stomach that was actively spilling, that they were able to wedge resect. No surrounding structures appeared to have injury, and then the single GSW injury to the left diaphragm. So it appears that epigastric wound went superiorly. Neurosurgery came into the operating room and performed a left-sided EVD. And then at the end of the case, the patient was, again, off pressors, not actively receiving blood products. So 2 drains were left, the abdomen was closed, and he was transferred to our trauma ICU.
Dr. Warner, you can chime in with questions or comments anywhere along the way. You are our panelist.
Yeah, you could go anywhere with this, Dr. Matecki. So this, I think that you get a lot of differing opinions about what to do while in the operating room and what is the utility of a fast exam in penetrating trauma. The epigastric gunshot wound with no second ballistic gives me a lot of pause because the possibilities are really endless for where that could go. What's your sort of thought on the initial primary? You mentioned pretty quickly that this patient arrested, but what's your sort of thoughts of the prioritization of that missile survey or your assessment, or how quickly do you try to put together what you're looking for in penetrating cases like this?
We have a pretty good routine. We've integrated well looking for holes in our penetrating cases. So of course we're doing our XABCD, but in our pre-brief, we usually discuss that we need to look for the holes in the bullets and the ballistics with sometimes a brief roll as we're usually right as we're finishing our primary survey. So we try and prioritize that and then go through more extensively and see what exact injuries we have, look at these extremity injuries and this and that. But we do try and prioritize it in the trauma bay. We have, the ED team doing their adjuncts in the FAST exam quite quickly. I mean, they're usually done with their FAST exam 5 minutes, if that. So, we have that going on as well, and that can be helpful for us. Ultimately, if the patient's not stable, we're going to the OR and penetrating trauma, or if they are stable, we're, potentially going to the CT scanner. So the FAST exam can guide us a little bit, but we usually have either direct visualization or 3D imaging soon after.
I'm going to throw one out here because I've got a question from Dr. Guo in the chat. You had a patient in shock. You had a wound in the epigastrium. You're already on the operating table. Did the abdomen warrant just being open? Dr. Warner just alluded to that. Dr. Guo, do you ever do a finger aspirate of the peritoneal cavity? How about that? Simple incision and stick your finger in, or did you think about something simple like that, Dr. Matecki, or a diagnostic aspirate of the peritoneal cavity?
I would
Go ahead.
just open the abdomen at this point because the patient is still unstable and there's not much blood from the chest. There got to be something in the abdomen.
Yeah, so the patient had pretty well stabilized after the pericardium was open. I think they were curious what the trajectory was. I think part of the thoughts were also, if this person has a retroperitoneal injury, great vessel injury, do they need any sort of interventional radiology? What other adjuncts do we need to bring in potentially before, opening the abdomen? I think keeping the OR ready was the right move. I think they had an extremely high likelihood of going back to the OR after that initial exploration in the chest, which is why they kept the OR prepped.
Got it. It's helpful. Okay. So now you've controlled bleeding in the abdomen and you're back to the ICU. I'm guessing there's a protracted ICU course coming, I'm guessing, for this complicated patient.
Yeah. He had some orthopedic evaluation for this distal radius fracture, but he did remarkably well in the first couple of days. He was following commands off of sedation. In his chest, he had some air leak, but he had no ongoing evidence of leak or bleed in his abdomen, and he was actually extubated on post-op day 2 off pressors on some nasal cannula, mentating much better than when he came in. However, on the morning of post-op day 3, he developed a worsening oxygen requirement, and his AM chest x-ray showed a much worse left-sided opacity. So this is post-op day 2 on the left side of your screen, and then this is the morning of post-op day 3 on the right side of the screen. Throughout the day on post-op day 3, he had worsening oxygenation, and the decision was made to re-intubate the patient. When they initially did their visualization in the upper airway, there was a lot of blood and mucus in the trachea that they had to suction out. When they were eventually able to get the ET tube in, they did an immediate bronchoscopy that showed thick plugs in the left main stem, mostly blood clots and mucus, and the patient was unable to be ventilated well. During this, he had a brief respiratory code that before the return of pulses, and then you can see as they performed the BAL and the bronchoscopy, they were able to clear out some of the plugs, but his respiratory status didn't really improve. So during the bronchoscopy, the initial ABG is actually on the right-hand side of the screen. So he was quite hypercarbic, but able to maintain at least some oxygen saturation. But after his bronch, he was able to clear some of his CO2, but he was really not oxygenating appropriately despite multiple interventions. So we again re-engaged our cardiothoracic team to place him on VV ECMO. He was cannulated at bedside in the ICU. These are his initial settings on the VV ECMO. Additionally, he had an episode of AFib during all this, which was managed with amio and cardioversion. He remained in the cardiac ICU for the next few days and gradually weaned down his ECMO settings, and we managed his other traumatic injuries concurrently. So on post-op day 4, the neurosurgery team removed his EVD. We did a gastric leak test, and which was negative, and he was started on feeds. We did an early tracheostomy in this patient, and he was mentating well enough to start trach collar trials the next day. And eventually, after 6 days on ECMO, his settings were weaned down enough that he could actually be decannulated.
Okay, there's a lot right there on that slide, Dr. Warner.
Yeah, I think a couple of questions. You know, it's a young patient, if I recall. Why don't you think he tolerated single lung ventilation for that period? Because I think in a lot of cases we get away with that if needed, sort of over the short term. Did he have some other shunts that contributed to this?
You know, that's a good point. I'm not exactly sure. His right lung looks pretty good. So yeah, I'm not exactly sure why he didn't tolerate it as well. He had no underlying pulmonary disease that I'm aware of.
Yeah, I think that, we sometimes, and in this case, penetrating less likely as contralateral contusion, but in sort of blunt thoracic wall trauma, I think we sometimes underappreciate the significant shunt contribution that pulmonary contusions play. In this kind of case with an airway injury, did he have some blood that sort of caused some obstruction on the contralateral side that, you can't really appreciate on X-ray? But I agree with you. It's to me, it's a little bit of a surprise that he would have not been able to tolerate for that period. But we commend you, right? I think these trauma cases, sometimes it's tough to get engagement from those teams, especially in moments of arrest. When we think about anticipated outcomes for ECMO centers and adding a trauma patient who's already arrested, sometimes that enthusiasm is probably not what it should be, because a lot of these folks have a very correctable problem over the immediate short term. And so I think that's awesome that you all didn't hesitate to pull the trigger. It allows the dust to settle a little bit. I think to be able to take stock of what are the injuries that we need to correct. But you don't always get that kind of support that you were able to. So what was that conversation, or how were you able to navigate that so quickly?
I mean, I think it was helpful that the cardiac surgery team was already involved in this patient's care and was
invested already.
for being in the chest. And I think, this is not the first patient with our first trauma patient that we've put on ECMO. And so we do have, I think, a pretty good precedent of asking them in cases where we think that they are able, the ECMO is truly a bridge to them healing their injuries. And so they are pretty open to working with us when we say, hey, we have a trauma patient, they have this injury pattern, and we think that they would benefit from some ECMO. They know that, we're asking for something kind of reasonable.
Excellent. One other question: the tracheostomy. So he'd been extubated, GCS 15. Does he need, do you think, early trach necessary for him?
I think given the lung pathology and the whiteout and the probably amount of contusion and laceration that he had, I don't think it was the wrong move. Just because it may have taken him a while of positive pressure. He could have needed multiple bronchoscopies afterwards to do the tracheostomy.
Yeah, totally agree. He's already failed once. Why put this person at risk, especially with a brain injury, right? You don't know what the secondary insult may be with that additional variable. So totally supportive, right? Don't let them fail twice in the same way. So I would commend you, I think, on a really complex case that a lot of potential pitfalls here that we could go into for the remainder of the afternoon, but I think we're getting a time message. So I'll defer to Dr. Bernard and Dr. Broker.
Okay, Dr. Matecki, wrap us up. Tell us that there's a happy ending here.
Yes. Here, I'll show you his chest x-ray. So this is his chest x-ray after ECMO decannulation, significantly improved. He did really well. He was taken out of the ICU. His mental status was considerably improved. He worked with PT-OT and was recommended for acute rehab. He was eating food. He was actually decannulated from his tracheostomy before discharge, and he went home 24 days after his injury. He did well enough that he was able to come back to our Trauma Survivors Day and actually talk with his care team and, tell everybody about his injury and how well he had done afterwards. So we are extremely happy for him.
What an inspiring case, a testament to your center, which has a long legacy of Trauma Survivors Day, holding Trauma Survivors Day and doing a big celebration. And we actually modeled ours here at Kentucky after yours there at GW. Well done.
Thank you.
Whole team. Okay, we're going to roll right into the next case so we can stay on time. We want to give Dr. Arjmand plenty of time. Her mentor is Dr. Naji Faruqi up at Northwell. Dr. Arjmand, you have the floor. You want to display your slides there.
Perfect. Thank you. Just need one moment. Okay. Okay. Can everyone see my screen?
Sure can.
Okay, great. Okay. Hi, everyone. My name is Shadi. I'm a PGY4 at Northwell Hospital, Staten Island University Hospital. As Dr. Bernard mentioned, my mentor is Dr. Faruqi. I'm presenting this interesting case with the title Beyond the Ribcage, a Hidden Consequence of Thoracic. And I would like to say I do have an interest in trauma surgery as they speak. And so I have no disclosures related to this presentation. So I'll start by presenting the case. It's a 61-year-old male with a past medical history of seizure and alcohol abuse. He presented to our hospital after a mechanical fall off of an air mattress. Initial workup that was done there, he was found to have left anterolateral 3 through 6 rib fractures. However, was found to have good lung volumes, and he was discharged home. That patient represented 6 days later to the same South Hospital with left-sided facial and neck swelling, slurred speech, blurry vision, and confusion. That the patient was subsequently transferred to our North site, which has like trauma capabilities. And a code stroke was called, and that image workup was negative. However, further CT scanning did reveal very significant left-sided subcutaneous emphysema with a left-sided, the 3 through 6 rib fractures and a pneumothorax associated. An image here. Some of the pretty significant findings of the subcutaneous emphysema are quite extensive, and some of the disruption of those left 3 through 6 ribs comminuted and moderately displaced fractures. So,
Dr. Arjmand,
Yeah.
I'm going to take you back just one. This is great. Thank you for the question for the panelists. So when the patient was there before, were they seen by the trauma service, or was this just the emergency medicine team? I'm interested in that. I'm interested in what the other panelists, Dr. Henry or Dr. Warner, would say about when the trauma service should get involved in rib fractures.
Yeah, I think that's one of the crux of this case in particular, is because the patient presented to our South Hospital, which does not have a program there. So they don't have the trauma capabilities. It's a very small community, like sister hospital of Staten Island University North. So no, the trauma team wasn't activated at that time. And the initial presentation, it was just managed by the emergency medicine team. And the patient was deemed, safe for discharge from their standpoint after a chest x-ray. So that is what happened that first presentation. Yes. And it wasn't until, I'm sorry.
Oh, please.
I know. And it wasn't until the patient had represented like a week later with the facial swelling and, basically the subcutaneous emphysema that was very significant. The patient was transferred up north, not really because of a concern for a respiratory standpoint, in fact, but more so they thought he was having a stroke. So, that's what happened. And when he came here, the trauma team was alerted after the imaging workup instead demonstrated subcutaneous emphysema and redemonstrated those rib fractures.
Okay, Dr. Warner, we have Dr. Serrani, a leader in the Chest Wall Injury Society. They think all ribs need attention. I'm interested in your comments, experts on ribs here.
Yeah, former president of the Chest Wall Injury Society, which I carry strong bias for. So Dr. Serrani, I know, is here, and I was sort of looking to see if his microphone got hot as we were talking about this. He said something profound, that no one with isolated rib fractures should ever have a tracheostomy related to that problem. And that was something that, to me, it just represented that it's not always that there's nothing to do. And for me, the trauma surgeon involvement, you typically don't have to do anything. But I think the knowledge that there are problems that come from this that we can correct. And that was his message, right? Is making sure that people know. But if Bobak's gotten his microphone unmuted there, I'll allow him to give us the follow-up to that.
Well, good morning to all. Sorry, I'm video off because I'm visiting my parents. I'm in their house, so with apologies. But thank you for the alley-oops. It's what I said was no one with rib fractures as their main injury, not necessarily isolated, but as their main injury, should get a tracheostomy and die without having had a chance to undergo rib plating. That's a much more wordy way, but somewhere along the lines is what I said. I think this is a fascinating conversation. I'm looking forward to hearing the rest of it. I'm curious to know. My question was going to be really at the end, which is, what kind of feedback did you guys give to the referring center, so that the next go around they're a little bit more quick to send them up to you guys because of the rib fractures. We can park and have that for the end if you like.
As far as that, this case was escalated to, from our trauma department to the ED department, kind of out of my scope. But I was made aware that this was, I'm sure that there was some communication about this being somewhat of a miss of sorts. I wasn't privy to those conversations, but I did hear that this was, brought to their attention.
Hello, this is Faruqi. How are you? So yes, this is part of our PI. We sat down, we figured out what was happening, and I think one of the most important things is that someone who has multiple rib fractures, pain, trauma team should be involved, and even if it's in a sister hospital, we now are encouraging calls out to the on-call trauma surgeon, at least to figure out what the plan is. So this was one of the policies that were reinforced after this case was discussed.
Was there any evaluation of this patient's sort of vital capacity? Did they have IS? Did they do any of those things that we normally do with our patients with rib fractures to assess whether or not this patient, because some patients can go home. I've had patients with more rib fractures than I would, if I just saw the number, I would say, oh my God, they can't possibly do that, and been quite surprised that they pull, 2,500 on the IS, and it's hard to say you can do better than that. You're going to be able to do better than that. I just wondered whether those things were done, and is that part of the evaluation that Even patients with a 1Z rib fracture should undergo and have that cleared before they're discharged.
Thank you for the question, Dr. Henry. So absolutely. On our discussion with the initial ER team, ER evaluation team, they did do an incentives parameter. I don't remember the number off the top of my head, but they said it was adequate. But as our practice, to make it more standardized, we look at the PIC score. And whenever we say that, if the PIC score is acceptable, the patient is doing more than expected, especially on the incentives parameter with good pain control, we usually follow up closely with them in the trauma clinic. But I think this was PIC score is a very is a different. Every score is different for every department. So with this is more of this was more of an educational opportunity for both the departments and standardize our practice.
That's helpful. Thanks, Dr. Perky. Great question, Dr. Henry. A question of clarification just before you go on, Dr. Arjmand. In the chat, this fall was from basically the height of a mattress. You said they fell off of an air mattress.
Yeah, my understanding is that it was a ground level fall from an air mattress. So I'm assuming it's like a slip and fall of sorts. I didn't see that there was any associated, from any of the documentation, even from.
And as far as you know, the initial film had nothing but ribs on it. There wasn't a missed small pneumo or something like that.
No, nothing.
Yeah.
Okay. All right. So the question to the panelists, what happened to this patient?
I don't think he fell on an air mattress. I think there was some suspicion raised in the chat about what his mechanism was. Because to be fair, you hear that story, I think trauma is pretty low on the radar of the emergency physician. But I saw some raised eyebrows, Dr. Henry, also when you were describing the height of this fall and the subsequent imaging we're looking at. A little suspicious about, was there some other violence inflicted on the patient, other things that they may not feel comfortable disclosing, also important to, I think, evaluate.
Yeah, no, mattresses are pretty deep now, but that would be an especially deep mattress, one would think.
Okay, tell us what happened, Dr. Arjmand.
Yeah,
Dr. Ramsey. Dr. Ramsey. Okay, go ahead, Dr. Arjmand.
Yeah, we do employ PTSD screenings, and then we do those like social surveys as well. But he did not really endorse any self-reported incidents. So we really didn't have much else to go off of if the patient themselves really reporting any other story presently than what he had told us. But yeah, it's pretty significant injury for that story mechanism. I'd agree. But just moving on. So just to continue with the case then, chest tube was placed after the trauma team was alerted, and the patient was admitted to the surgical ICU for continued monitoring, management of his pain, the pneumothorax, and also had significant hyponatremia in the setting of being a user of alcohol. He stayed in the ICU for several days. The chest tube was subsequently removed with improvement on chest x-ray on hospital day 4, and he was downgraded to the surgical med-surg floor. However, the patient had persistent complaints of pain. We were optimizing pain control, but it wasn't helping. So the team deemed it appropriate to repeat a CT scan at this time. And it was at this time that the CT scan demonstrated a small lung herniation adjacent to the displaced fracture. Image here. That really does demonstrate that. Although there are on that prior image some changes that you can note, even the radiologist didn't really, mention or note that there may have been like a lung herniation, but instead like some pleural, like inflammatory changes of the subcutaneous tissue. But maybe that indeed was actually lung that was herniated even to begin with. So we found that this was the root of his persistent pain. And just another image on the coronal. And why you can kind of tell it may have been missed is that there's lots of subcutaneous emphysema, and radiographically they could really obscure the image, but it was this second image, unfortunately. And so the next was to open it up to the crowd. What would you do next? Continue to monitor for symptomatic relief, discharge the patient, or maybe consider surgical intervention?
I just have a couple of questions before we just go to the panelists there. of clarification. So the patient wasn't considered for any sort of rib fixation initially when they're in the ICU. That's my first question. And then the indication for the CT scan was persistent pain. And is that a routine, or how do you distinguish persistent pain in this patient from persistent pain in any other patient with rib fractures? And I'm interested in what the panelists have to say about any of those questions or the ones on the screen here, Dr. Kong, Dr. Henry, Dr. Warren.
My understanding is that no, the surgical intervention was not initially offered upfront for these rib fractures for this patient to begin with. And I wouldn't say it's routine at our hospital to perform a CT scan for the kind of just pain only. But I think that that's what the team had decided at the time was a good investigative tool to see if there was something that was being missed because his pain wasn't under control. And despite his vitals, his parameters being okay, he just still had persistent pain. So they wanted that for further investigation.
There's a question in the chat about what was the cause of his weakness.
So what was the cause of his weakness? I think initially there was the report because I think that they were under the assumption of a stroke, that there was like dysphagia, slurred speech, and potentially weakness. But I think after our trauma team had evaluated him, this was kind of like a red herring, or just kind of instead was just the symptoms of facial swelling and edema from the significant subcutaneous emphysema that reached his face. So there were no like actual further complaints of weakness beyond that. And after the subcutaneous emphysema did improve with the chest tube placement, those symptoms had resolved.
Yeah,
Okay.
on that CT scan, it looked like at least that one rib fracture was displaced, and I think with the herniation, I think fixing that rib or plating that, at least that rib fracture, I'd have to see the entire CT and maybe the recons. Did you guys get the 3D recons where the images were?
No, no 3D recons were obtained
Okay.
at that time, but I do agree one of the ribs out of this set were pretty significantly displaced.
Yeah. So I think it's okay to, I personally think that with pain, it was, I don't know how well he was doing. There are people who like manage not to be intubated, but are just sort of hanging on with regard to the level of their saturation and the amount of pain medicine they're taking. You have to assess those things and kind of put it all together. I can't say that I have a 1, 2, 3, 4 algorithm that I use. It's more of a gestalt when I'm looking at these patients, but I certainly think this guy would fall heavily in the category that even if it was 1 or 2 rib fractures, I think it's worth going after fixing those to probably improve his overall outcome.
Yeah, I would totally agree. I think this is interesting because this interval of imaging is atypical, and you're almost watching the natural history of the neglected chest wall hernia, right? And in these cases, often patients will languish for weeks because they've been told there's nothing to do for these rib fractures. You'll have pain for 6 or 12 weeks, and then they show up with a very disfigured chest wall with a significant hernia, now with transmitted posterior fractures from that stress. So I would totally agree with Dr. Henry, and I think there was a comment in the chat as well about intervening earlier before that anatomy is totally distorted. You could probably do a much more minimal resection as far as fixation as far as morbidity goes, to get those ribs fixed and to stabilize the chest wall, and probably prevent you from maybe ongoing air leak that's sort of shunted out into the sub-Q away from your chest tube because of this lung laceration, which is a little bit what this picture looks like.
And I think that even though this patient may be like outside the typical early window for fixation, that all that sub-Q air kind of prevents the scarring and healing that you normally would see, that might make that a more difficult procedure to do. I actually think this would not be that hard to do, even though you're a little further out than you have been. And I actually have seen patients who presented after like a vigorous cough and developed a spontaneous sort of pneumothorax, actually tear their chest wall and develop neck fash from leaking out. If that, I guess if they have pneumonia already and their bacteria in whatever's in the lung, they can actually develop soft tissue infection related to this. So that's also something to keep an eye out for while you're watching these people with these bad, with a lung herniation like this as well.
I'm interested in the perspective of Dr. Kong in New Zealand. Dr. Kong, how would you approach this particular case? Are there systems or routines of care for deciding who gets rib fixation in New Zealand? Interested in your thoughts.
Interesting. First of all, I think we are actually one of the few centers who actually do rib fixation. So not many of us actually do it. Secondly, we are fairly selective with our rib fixation. So, but I think I do agree with with our colleagues here. I think certainly for this case, I think I think I personally would agree that for this particular case, rib fixation would definitely be indicated. But I think in general, we really only do it for the mechanical instability, and a lot of the time, patients that we would consider those that we just could not win them off the ventilator. Then we actually would consider. Every other case would be just on case-to-case basis. So we're definitely probably a lot more conservative than a lot centers. Primarily, I think is resource issues and also just not, I suppose, just again, not many centers actually do it. So then we sort of just agree among our group, this case, probably then we're going to do it rather than do it for most people except some, if it makes sense.
It does. So you're getting a fair number of referrals since your group's one of the few that does it.
Yes.
Yeah, got it. Okay. All right. Dr. Arjmand, back to you. We have 9 minutes here. I suspect we're going to get down to some technical aspects here.
Yes. Okay, I'll continue then. So we talked about what we would do next, and alas, we took him to the OR. Thank God. So we took him. It was hospital day 7 for the combined, hybrid procedure, left-sided VATS with a mini thoracotomy, rib fixation of ribs 4 through 6, and also a cryoablation. 3 through 8. And there was a wedge resection of this incarcerated piece of lung that was herniated. Intraoperatively, it was the lingula of the left lung that was incarcerated between ribs 5 and 6. And basically, we did a cut down from the skin down onto that portion and kind of freed it up from the, externally and extrathoracic. And then we, from another port with the camera, we were able to thoracoscopically observe that. I have some pictures as well. So we Frenchly dissected around it and pushed it back into the chest. So this is a view from the inside of the herniated portion of the lung, which did have a good amount of scar. I think that this is probably, he presented, 6 days late already to begin with. And then, I'm sorry, and so he had represented 6 days after the initial onset mechanism. So there was a lot of actually already adhesions that we had to dissect down as well. And then this is the rib plating system that we use, the intrathoracic Biomet Advantage rib plating system, which was really cool. And sometimes, from my understanding, because I'm also novice in this, but just that, extra thoracic rib plating systems are more common. And so this was really cool to learn the intrathoracic maneuvers and being able to wire them in, bring them into the chest and pull them up and out. And then we kind of screw them down and then break off these parts to the top of them. And so we're able to fix them intrathoracically, which was really neat. And this is a view from our mini thoracotomy and a wound protector of the nicely aligned, or for example, one of the ribs you can see very clearly put back in good form after that. And so post-operatively, the patient did excellent. Patient was extubated immediately post-op to 2 liters of the cannula, tolerated the procedure well. The patient, I think, spent like 1 day postoperatively in the critical care unit, was downgraded immediately to the floor with a chest tube that was in place after the procedure. That chest tube was, water sealed and subsequently removed with the improvement on the chest x-ray and low outputs and good compliance and volumes in central spirometry and pain control by post-op day 4. And the patient was subsequently discharged post-op day 7. We've seen him recently post on a 3-month follow-up, and he's doing excellent. He has complaints of some left-sided numbness over the incision, but aside from that, his pain is under control. He's doing well from a respiratory standpoint as well. And so,
let's just ask the panelists here. Technical approach. What set do you use, or do you use different kinds of sets? And what's your technical approach, Dr. Kong?
I actually do open rather than intrathoracic ones, and I don't think in my environment I would be interested to hear from the rest of my colleagues here. So I don't do intrathoracic plating. Essentially I only do the open one. So I was just wondering about the decision of doing intrathoracic versus extrathoracics, whether there's any consideration as to, is that your default approach, or is this how would you decide?
Dr. Henry, what do you use?
I tend to mostly use the extrathoracic approach. I like the I forget the brand, the one that clips around the rib, where you sort of have that attachment. I like that one. That's my favorite one, but I think you have to be willing to use a couple, have a couple that you use, because sometimes the anatomy of the fracture is better suited to one system versus another system. And we have access to, like, I think 3 different systems here. I've never done the intrathoracic one yet. That always bothers me, because I worry about what happens if you get an infection, if you get an empyema or something like that post procedure. What happens when that occurs, but I don't have much experience with the intrathoracic kind, so I don't have much to say about that.
I agree with Dr. Henry. This is one of the primary concern is, what do you do if they get infected? And I think that's probably one of the primary sort of resistance in pursuing that, certainly in our environment. So thank you for bringing up that point.
Dr. Warner, your technique, and then from all the panelists, when do you decide if you're going to do thoracoscopy and clean the chest out as well? Dr. Warner, your technique.
Yeah, extrathoracic for me, I'm a loyalist to a single company that I haven't had any fractures that I couldn't approach with that particular group. But I'll be agnostic to industry for the purposes of this meeting. But I think that I do have the same concerns that Dr. Kong and Dr. Henry have mentioned about the intrathoracic system. I have a partner that's very interested in that device and likes it predominantly. The appeal to me would be sort of the osteopenic patient, where the external fixation and bicortical securement and fixation may be a little bit difficult with those ribs that aren't quite as robust. And I think that from a bone healing and physics standpoint, the internal system makes sense for that group. But I have not utilized that particular system for the exact concerns that have been articulated here. I think you can do a very minimally invasive approach with an extrathoracic system. You had visualization, right, that you need for that in the pictures you showed, which actually outlined exactly what Dr. Henry predicted, which was no callus formation, right? Very little in the way of difficulty and the need to perform that, because, this is a dynamic process, and the ribs and the herniation prevented that healing from beginning to occur. So I don't think that intimidation of, right, we're looking at almost 2 weeks. A lot of people would say they're outside the window. And so I think that's very important to recognize that little bit of protection. And as the chest worsens, you don't run into those same problems where you might have a displaced fracture that's beginning to heal. So it was nice that she highlighted that. I do have one sort of interesting point. The patient complains about their numbness. Did you discuss why that may be and what they should expect based on what you did?
Not personally, but I mean, this was a follow-up that was like months out. So, I mean, as far as like the cryoablation, I don't think I would expect the cryoablation to last that long. I don't, but that's what I just was like looking at the follow-up, and then he just followed up just recently saying that he still complains a little of numbness. So it could be secondary to the cryoablation or just like kind of peri-incisionally. I think that that was discussed was one of the things when before he left. But as far as the office visit, I didn't see any documentation as to whether that was like reviewed again. But yes.
Dr. Henry, Dr. Kong, do you do the cryoablation in addition? Do you ever do this?
I haven't leaned into that yet, but there are members of my group who are definitely zealots. I don't know if I should say zealots, but really lean into it and think it works quite well.
Personally, no. But again, there's been quite a lot of interest of late with the topic. So yes.
How about intercostal nerve blocks?
Yeah.
Liposomal, bupivacaine, anything like that, or
epidural. Yeah, I have used the OnQ, I guess, the little fillable pumps. I've used those occasionally, and I've also injected with the liposomal. All these patients usually have the pain management service involved with their management as well, because otherwise they wouldn't be getting their ribs fixed. So we usually definitely lean into all the modals that we can use to manage their pain the best we can.
Dr. Kong in New Zealand, analgesia.
Yeah, same in our environment. In fact, they get seen routinely by the pain team, every single one of them. So the management heavily dictated by the actual on-call pain team. But I'd say local regional blockade in my setting, they do it very well. So there's usually very little resistance as to doing any local blockade, thoracic epidural, or erectus minor block of that sort. Yeah, so I'd say probably not in the intercostal block, probably not very often done in my setting, but certainly epidural very commonly done.
Super. Well, it's the top of the hour. We have the two surgical residents present some great cases here, happy endings in both. We appreciate you all being here today. It's intimidating on a big group like this. Thank you for being here. We appreciate your mentors, Dr. Sarani and Dr. Faruqi, being here. And of course, our panelists, Dr. Kong from New Zealand, Dr. Henry from Maryland, Dr. Warner from here in Lexington. On behalf of the AAST and the Pan American Trauma Society, thank you all for coming to the case conference today. We'll see you next time. Every week, right, Dr. Henry? Every Monday?
Yep. Absolutely.
What a great opportunity. Okay, everyone, enjoy the afternoon. Thank you all.
Thank you all.
Thank you. And don't forget the trauma acute care surgery webinars on mornings, third Saturday of the month.
Thanks, Dr. Henry. Dr. Brecker, thank you very much.
Yeah, thank you. Have a good day.
Thank you.